Well, thank you very much for the kind invitation to present my work here. Thank you, Dr. Preventer, Dr. Shaw, and the program committee. Thanks to Ms. Madrigal for her generous patience as we navigated these things. Over the next 7 minutes that I've been allotted, I have nothing to disclose. Over the next 7 minutes, I'll seek to define the social demographic disparities in amputation and revascularization. I'll then discuss potential mitigating strategies at the institutional, at the organizational, as well as at the national level. Blacks in America are 5 times more likely to undergo an amputation as compared to white Americans. Now, we know that when you look at blacks who present for their initial vascular intervention, blacks tend to have a heavy load of vascular disease, i.e. more likely to have symptomatic carotid artery disease, more likely to have symptomatic aneurysms, and more likely to present with critical limb-threatening ischemia. This has led some to suggest that there might potentially be an underlying biological basis for this disparity. We also know that there are different national trends in terms of disparate treatment for critical limb-threatening ischemia. When you look at a nationwide inpatient sample database of an 8-year period and queried all patients presented with chronic limb-threatening ischemia, all patients undergoing revascularization versus all patients who underwent amputation, it seems that blacks tend to be underrepresented in those who are being revascularized and overrepresented in those who are being amputated, and white tend to be overrepresented in the revascularization group and underrepresented in this. Some of these trends have been seen in several studies around the country, suggesting that there might potentially be some disparate treatment. Now, this is not only limited to race ethnicity. Over the nation, individuals in the lower socioeconomic strata are more likely to undergo amputation. One statewide database in California in 2009 suggested that if you look at individuals who stay in the more black and brown areas, such as South Central Los Angeles, compared to those who stayed in the areas of more wealthy areas, such as Beverly Hills, there's a 10-fold greater likelihood of undergoing an amputation from diabetes, 10-fold difference. Now, it appears that according to a socioeconomic strata, the likelihood of undergoing an amputation versus undergoing revascularization seems to happen in a stepwise fashion. We looked at the nationwide inpatient sample database and looked at all patients presenting with critical limb-threatening ischemia and those who underwent a procedure at that same admission. And we stratify these patients according to different income strata, that is first, second, third, and fourth medial quartile income. So if we use the wealthiest individuals, fourth income strata, private insurance as a control. As your income strata went lower, your risk of undergoing an amputation versus revascularization at that same admission increased. So we are talking about a risk of going up at 50% more likely to undergo amputation rather than revascularization with private insurance. And then when you move to less desirable Medicaid insurance, that would jump up even more significantly. This happens to be that not only are lower socioeconomic strata patients more likely to undergo an amputation, even following bypass, these patients seem to have worse outcome. Again, this is a different database. Using a nationwide readmission database, following surgical bypass, when we compare patients in the highest income quartile, fourth income quartile, versus those in the lower income quartile, the richer patients have lower rate of readmission and also have lower rate of eventual amputation following surgical bypass. While there's a lot of debate as to whether this is potentially primarily biologic or primarily social or primarily sociologic, my own hypothesis is that this might be a biologic response to environmental stress. My suggestion, my hypothesis is that long-term socioeconomic deprivation affects the vascular system and leads to more severe vascular disease, but that is for another talk. How do we potentially mitigate these disparities? Around the country, there's been multiple institutions that have adopted these multidisciplinary clinics. Joe Mills was famous for starting the Flow and Toe Clinic in Arizona over 2 decades ago, and the multiple institutions have adopted these clinics with podiatrists, vascular surgeons, vascular medicine individuals. And when you look at a meta-analysis of about 4 years ago, done of about 33 different multidisciplinary clinics, the evidence would suggest that these multidisciplinary clinics reduce major amputations by about 94%. I'd like to give a shout out to Society for Vascular Surgery and certain organizational things that the society has done, specifically vascular care for the underserved. These are organizational initiatives done at the national level. Specifically, SVS has 3 pilot programs looking at areas in Oklahoma, looking at Arizona, as well as areas in California. We look forward to see what these organizational things will bring to bear. Affordable Care Act, which was implemented in 2010. We know that there are 40 states, as well as the District of Columbia, took upon themselves to expand Medicaid coverage. It is clear that with this overall uninsured status in the nation has decreased significantly. We went from having almost 50 million individuals who are uninsured to having just over 20 million individuals who are uninsured. How has this impacted potential likelihood of revascularization amputation? We looked at the state inpatient database in Maryland. Maryland was an early adopter. So we are looking at the 2007 to 2009 as compared to 2018 to 2020. So period before ACA and period after ACA. So now looking at all patients who present with critical limb-threatening ischemia, and we are looking at those who were revascularized versus those who underwent amputation. Pre-ACA, we saw that about 56% of patients coming with CLTI were undergoing amputation as compared to 44% undergoing revascularization. Post-ACA, we are having 22% of patients undergoing amputation versus 77% undergoing revascularization. Now, I'll hasten to say that this study design is highly suggestive, but it's not necessarily conclusive that the ACA has done it, though we can say it's highly suggestive. This is true according to this was true according to across different racial ethnic demographics, that the predicted probability of undergoing revascularization as opposed to amputation with following the ACA, all comers was about 40% likelihood of revascularization versus about 70 to 80% likelihood of following the post-ACA. When you look at all the different demographics, all the likelihood, all the different things that suggest that somebody may be more likely to be revascularized or amputated for chronic limb-threatening ischemia, looking at insurance status, comorbidities, race, ethnicity, seems like the one biggest factor was the Affordable Care Act. Post-Affordable Care Act, individuals were 4 times more likely to be revascularized versus undergoing amputation. So thank you very much for your time.